Hello, Dr. Ken Gilman here. I'm updating the information that I publish about the tricyclic antidepressants. I thought I'd do a little video. I have done one before, not for a good while, but there's been a little bit of development, not much, a little bit of development in publications about tricyclics, just enough to make me feel I needed to update the seminal review paper that I published way back in 2007. The appreciation that these older tricyclic antidepressants are useful and good drugs for people with more severe melancholic-type depressive illness has increased, I think, perhaps because now that these newer drugs have been in use for such a long time, people are gradually beginning to realize they're not quite what they've been held up to be. And a lot of patients just don't get an adequate response. So people are starting to think about the tricyclics again. And what I want to emphasize briefly in this little introductory video is the long, I mean long, I think it's close to 10,000 words, the new update on tricyclics that will be posted on my psychotropical website very soon. It's good to be able to publish something a bit longer like that journals won't publish, because there's lots of interesting stuff to cover and people can easily skim through it and find the bits that are relevant and useful for them without necessarily reading all of it. People have stopped using the tricyclics because they have too many side effects and because they're dangerous when people take overdoses of them. Not. Both of those statements are essentially incorrect. All drugs have side effects, and more potent drugs tend to have more side effects. It's not always the case, but there's a fairly strong tendency in that direction. But the truth is, if you look at the very few studies there are that have carefully controlled the dose of individual tricyclic antidepressants and compared them with the newer drugs, the discontinuation rate, either from failure of treatment or from side effects that have necessitated or precipitated people wanting to cease the treatment, are pretty much the same. There is not a great deal of difference. Furthermore, and this is something which has been conveniently glossed over by everybody who's advertising all these new drugs, the side effects, the medium to longer term side effects especially, have been ignored. SSRIs have quite significant medium to longer term side effects. Even the short term side effects, like the sexual side effects, were willfully and almost deceitfully ignored in the trials. Anybody who's used a tricyclic and any doctor of any perspicacity who has given them to patients would have noticed very quickly that almost everybody gets significant sexual side effects with SSRIs. And especially for younger people, those are really major problems. But you look at all the early studies where they compared SSRIs with everything else, that was hardly mentioned. So combine that with the longer term side effects of SSRIs and the various other similar drugs like SNRIs, like venlafaxine, heaven knows what. And I suspect you'd find that some of the TCAs actually have a lower side effect discontinuation rate than many of the newer drugs, particularly nortriptyline, for instance, which I used to use a lot in combination with sertraline or escitalopram latterly, just before I retired, to get the true SNRI effect, which you possibly don't really get with duloxetine and venlafaxine. Nortriptyline has a very favourable pharmacological profile, and Even amitriptyline and clomipramine, if used carefully with therapeutic drug monitoring or careful adjustment of the dose versus the side effects. So various of the tricyclics have a much more favourable side effect and tolerability profile than many people would have you believe. Another major aspect of the argument against using tricyclics more often as first or second line treatment is their supposed toxicity and overdose. And that is where some of the new data clarifies the picture a little bit. And to summarise it briefly and quickly, what it all adds up to is that the overall toxicity of the selected agents, the individual agents, tricyclics, is not significantly different to the toxicity of many of the newer drugs. It's something of a myth. It's a distortion of the facts, which is not surprising. I mean, these drugs have been huge billion-dollar earners. Most of them, I'm sure, have earned billions, multiple billions of dollars for their manufacturers. And in order to sell them, obviously they employ a lot of people to spin the data as favourably as they can and exaggerate. It's inevitable that involves exaggerating or maximising the supposed ill effects of other drugs, especially the older tricyclics. So that's the source of a lot of the misinformation, I guess you have to call it. The cardiac side effects of tricyclics are actually minimal. They're in fact type 1 antiarrhythmic agents. They're not associated with any increased incidence of cardiac sudden death or arrhythmias or heart failure or stroke or anything else. Indeed, of course, they reduce people's blood pressure. So that aspect of the supposed disadvantages is nonsense. To the extent that they are slightly more toxic if you take a larger, sorry, I shouldn't say they. One of my hobby horses about this is that any statement that says the TCAs is nonsense, because they're a dissimilar group of drugs. They're a heterogeneous group of drugs. So desipramine at one end of the scale, if you like, is virtually a pure noradrenaline reuptake inhibitor, and in doses that fully inhibit the noradrenaline reuptake mechanism, it has very little other effect, perhaps a tiny bit of antimuscarinic effect, dry mouth, blurry vision, but almost nothing else. At the other extreme, you've got doxepin, which shouldn't really be classified as as an antidepressant at all. It's a specific antihistamine, a specific H1 antagonist, and it's a brilliant anti-allergy drug, whether it's eczema or even asthma, or rhinitis, sinusitis, pruritus. It is still the most potent H1 antagonist on the market that's legal to use in humans. Put that in your pipe and smoke it, modern drugs. It's brilliant. I've seen patients who've had extremely distressing pruritus, itchiness of the skin, sometimes caused by antibiotics or going yellow. You know, what's that thing where bilirubin, where people's bilirubin goes up and they get jaundice and go yellow. Well, that causes really intense itching. And doxepin will absolutely knock that on the head when no other drugs work at all. So there you are. You've got a huge discrepancy between those two extremes. And you can't talk about those two drugs or any other members of the so-called tricyclic group in the same breath meaningfully. You have to compare each one individually. So you have to compare the toxic effects of nortriptyline, for instance, with individual other drugs. And the relevant thing there to mention straight away is that nortriptyline may in fact be less toxic in overdose than venlafaxine. The whole business of the toxicity of these drugs in overdose is fraught with difficulty in analysing the data and comparing one drug with another. And I think often people have made statements which are unduly dogmatic on an insufficient basis. I'll give one example of that. It's not appropriate to go into all the details of that in a talk like this. It's just too complicated. It's dealt with in writing in the paper for anybody who's interested. But as an example, even if, let's say, amitriptyline is a little bit more toxic than, say, venlafaxine, if it actually works a bit better for the treatment of melancholic depression, where the suicide risk is very significant compared to less severe depression, 10% of people with severe depression commit suicide. Even if it is a little bit more toxic, if it works better than venlafaxine, and a lot of experienced psychopharmacologists would agree with me that there is pretty good evidence that that's the case. The evidence that clomipramine is even better is even stronger, in my opinion. Even if it's only a small improvement over something like venlafaxine, the risk of actually dying because of your illness and its treatment is lower. And one of the factors people haven't considered and discussed is the period for which people are at risk. Obviously, if you come to me with severe depression and I think you might be suicidal, and I treat you with amitriptyline, I'm going to be careful, quite probably, to have you in hospital to get the treatment stabilised and make sure you really are improving, in which case the risk of suicide is highly likely to be over by the time you leave hospital. So there's no danger there because the administration of the drug's being supervised. But even if people are at home and you think there's a slightly increased risk of suicide and they don't want to go into hospital, then it's easy enough to give small supplies of the drug so that there isn't enough for people to take an overdose and see them weekly, or to have a relative or some suitable person manage the supply and give it to the patient as required. So there are lots of ways of reducing the risk of people taking an overdose of a drug without using a less toxic drug. But the point is, the time period they're at risk for is quite short if the drug works better. Whereas, if people, as so frequently happens, and I'm sure many, many people listening to me now will relate to this, they get put on an SSRI, whatever, and left on it for ages and ages. They get a little bit better, but not properly better. And the percentage of people who kill themselves in that situation is more or less the same as the percentage of people who aren't actually treated. So that's not very successful treatment, is it? But they're left on it for months, years, many years. So the period for which they're at risk is hundreds of times longer than the period that somebody who has successful treatment with a slightly more toxic drug, if that's actually true, like amitriptyline, is. So I think you don't have to be Einstein in your mathematical ability to realise that it's obviously a win-win to have a slightly more toxic drug and have a risk period of a few weeks until you get better, rather than stick with a less effective treatment where the risk period is longer and longer and longer. No prizes there. So that's a really important point. So that's two things. The two major objections people have, well, three. Side effects, not much difference. Toxic effects, I've just dealt with. And whatever the other point was. I've forgotten what the third point was now, but you'll remember it, I'm sure, if you've been listening. So those are some really important basic points about the use of tricyclics. I'll say a little bit more about the statistics, I suppose, or about the evidence, the statistics sort of come into it, although the statistics are pretty dubious half the time. I mentioned a minute ago that clomipramine probably does have the strongest evidence for being of superior effectiveness for severe depression than any drug. And when I was writing this very long update of the TCA pharmacology, one of the things I came across which absolutely astonished me was a new summary analysis of the Danish University Antidepressant Group data, which I've always thought is very high quality data. And most of the other experienced psychopharmacologists I speak with agree with that. It's not just me that thinks that. Again, I won't go into detail about why we think that data's better quality data than most of the other data available, but it is, in my opinion. And they also did proper therapeutic drug monitoring of the plasma levels of these drugs, clomipramine, and I think the other drugs they were comparing it with. And what I discovered when I did the review was that somebody had produced an excellent reanalysis combining all of the data that they published in a series of 4 or 5 different papers back in the late 80s, early 90s, around then. I can't even remember when it was, about then. Karg Sorensen, I think the fellow's name was, Kargh, Danish or something Scandinavian. That paper was published in 2004. That's 20 years ago. And I thought, gosh, how come I didn't see this before? How did I not know about this? It slipped through the net. Well, it was in an extraordinarily obscure journal that I've never heard of, never ever heard of, and a journal that isn't in the database of the National Library of Medicine. And I'm not an expert at searching all these different databases, but I don't believe it's in any of the other commonly used databases. I just found it trawling through some references I'd got on Google Scholar, which, although it's not so easy to use in a way so specific as some of the other databases, it trawls in a very wide range of stuff, and it trawled in this. And when I looked to see how many times it had been cited, because I thought, gosh, I need to know who cited this and have a look at what they've said. I was speechless. It has not been cited once in the peer-reviewed literature since it was written and published in 2004. So how come all these clever people at these big universities and centres can't find it when I can? Interesting. I think that shows you that people don't do their research as thoroughly as they might quite often. But I think it also shows you how little interest there is now in these drugs. People have just, a bit like the MAOIs, people have just written them off. New must be better. Ha ha. The older you get, the more you realise that there is nothing new under the sun. So, there you have it, really, for the selected members of the TCA group, like amitriptyline, nortriptyline, and clomipramine. If somebody said, which 3 do you think doctors ought to know about, I would say that. Amitriptyline, clomipramine, because there's jolly good evidence that they're more potent and are more likely to get you better. And nortriptyline, because it is such a good bridging drug. It's so good to combine with an SSRI like sertraline or escitalopram to get a true SNRI effect. And then if that doesn't work and you need to take an MAOI, you can just stop the SSRI and you're less likely to relapse badly because you've still got the nortriptyline to keep you going. And then you can once the SSRI has washed out, you can then add your MAOI antidepressant and either continue with the MAOI plus the TCA, plus the nortriptyline, or stop the nortriptyline if you don't need it. So a wonderful combining and bridging drug. So those are the 3 tricyclics that I would strongly recommend doctors in the earlier part of their career understand and become familiar with. The pharmacology of them is pretty simple. Basically, nothing's changed since my original review paper, which I proudly repeat is the most highly cited paper in this field in probably the last 50 years. Somebody contradict me if you can, but certainly the last 30 years. It's certainly the only highly cited paper, or well-cited paper, that goes into the pharmacology in any detail at all. So it is the reference paper for this. And there's nothing to add to that since. I don't think there's any new receptor pharmacology data on these drugs that isn't in that paper. So apart from the things I've spoken about here, there isn't anything pharmacologically to add. So there you are. That helps you to understand why TCAs remain such important drugs for people to know about and familiarise themselves with and use more often. I would be of the view, as I've explained in the paper itself, that a proportion of patients should still be treated as a first-line treatment with a TCA. It depends exactly what you mean by first line, because of course nowadays almost everybody's going to be given one of these pseudo-antidepressants like an SSRI by a GP. So in that sense, nobody's actually getting first-line treatment with a TCA. But almost anybody who's referred to a specialist with depression is likely to be a candidate for immediate transfer to a TCA. As people who are familiar with my work may realise, I would tend to have treated people with a combination of sertraline plus nortriptyline rather than clomipramine, simply because it's more flexible. But you get patients who really only want to take one tablet at night and don't want to be bothered with 2 different tablets, and other similar sorts of reasons for not wanting a slightly more complex treatment regime. So they might want to take clomipramine rather than have 2 different tablets they have to take, one in the morning and one in the evening or whatever. But that aside, TCAs as a first choice treatment once people get to a specialist, and certainly very serious consideration should be given to them as a sort of second choice treatment. If you're getting to the stage of thinking, well, might you use an MAOI, or might you suggest they could consider ECT, then you should certainly be looking at a tricyclic. And personally, I would rather take clomipramine than venlafaxine. I really don't think venlafaxine, or duloxetine for that matter, are as effective as clomipramine. So there you are. That's a relatively brief update about the tricyclic antidepressants. Thank you for listening.